So we're going to pick up where we left off with a part 2 to chapter 47. Um, uh, we're going to start off with just talking about some of the settings or some of the other um, kind of effects of positive pressure and lung mechanics. First one is time constant. So we've talked about inspiratory time and expiratory time and how those are affected by respiratory rate and flow rate. But the concept of a time constant is really talking about how much time it takes for um, that inflation and deflation of the um, lung tissue. And this is going to be affected by things like compliance and airway resistance. So typically, if compliance or airway resistance increases, then the amount of time it takes to inflate that alveoli is going to also increase. And why this is important is when we start thinking about different disease processes and their effects on our resistance and compliance, we're going to need to be making adjustments to our patient's inspiratory time based off of those pathophysiological things that are happening in the lungs. So, like for example, your book gives 3 examples. So for your asthma patients have a very, very, very high airway resistance. So typically when we're treating asthma patients and we have asthma patients on mechanical ventilation, they're going to do better with that increased airway resistance. They're going to do better with an increase in their inspiratory time and their expiratory time. So asthmatics need to have that long inspiration, long time for expiration in order for the flow rate to be able to overcome the airway resistance that those patients experience getting air in and getting air out of their lungs. So these patients usually don't tolerate very fast respiratory rates then because they need to have that extra time for inspiration, expiration. Our COPD patients, on the other hand, um, usually have a little bit easier time with a shorter inspiration. So they usually like faster flow rates, shorter I times, and then but still need that long expiratory phase due to um that lack of elastic recoil and um uh, that kind of extra time needed for that increase in airway resistance during expiration. So our COPD patients usually have a short I time and a long expiratory phase. That usually is what they tolerate the best. Patients with ARDS, these patients usually have a very, very, very poor lung compliance. So their issue isn't airway resistance, but decreased lung compliance. So with decreased lung compliance, they're going to need a shorter I time, a shorter E time, which is helpful because these patients usually need to be managed with very low tidal volumes. So this short I time, short E time allows us to be able to ventilate them at much higher rates than our COPD and asthma patients. COPD asthma patients are always going to be the ones that we're going to be trying to balance their time constants, their respiratory rate and minute ventilation needs with trying to avoid that gas trapping. Okay, so the next section in your book talks about pressures and the pressures that we are concerned with ventilation. So our peak inspiratory pressure, again, is a pressure that's necessary to overcome the airway resistance and compliance of the lungs and chest wall. Our P plat, or our static alveolar pressure, is taken by doing that inspiratory hold during inspiration. Okay, what this P plat tells us is it tells us how much pressure is needed to keep those alveoli open without having to overcome the airway resistance. So really the difference between your plateau pressure and your peak inspiratory pressure is airway resistance. Okay. And that's calculated out down here by pip minus plat divided by the flow rate. Okay. Your static lung compliance is is the change in pressure over the change in volume when there is no flow, because that's the meaning of static. So when there's no airflow going through the lungs, the static lung compliance then really is a representation of just your lung compliance and your chest wall compliance, and doesn't factor in airway resistance like your dynamic compliance does. So we look at these things because we monitor these things in order to track changes in the patient's lung condition. If we start seeing a gradual increase or a decrease to those plateau pressures, that can signify changes with the patient's lung tissue that might need to be addressed. Overall, it's really important that we're monitoring the plateau pressures and making sure that they're less than 30 centimeters of water pressure. Okay. Because after you get above 30 centimeters of water pressure, that's where that barotrauma to the alveoli can start occurring. Okay. Next one, next pressure we've talked about already is that mean airway pressure. So mean airway pressure is the average pressure across the respiratory cycle. So I think I drew this on the board for you guys before. This is that pressure waveform, right? So your pressure waveform looks something like this. Your mean airway pressure is the area underneath this waveform. So it's kind of if I add all of this up, this green area here, and averaged it, this green area here represents my mean airway pressure. Okay. So mean airway pressure is going to be changed by any changes to the patient settings that are going to increase or decrease the area under this curve. Mean airway pressure is also closely tied to oxygenation. So it's a direct relationship. So as mean airway pressure increases, oxygenation improves. As mean airway pressure decreases, oxygenation also decreases. So obviously we've talked about this before. The easiest way to increase our mean airway pressure would be to just increase this baseline. So if I increase my PEEP to here, obviously I'm increasing the area underneath this curve, making a higher mean airway pressure. I could also increase my pressure control or my tidal volume, which if I might increase my tidal volume, I'm going to need to increase my pressure gradient. If I just increase my pressure gradient if I'm in pressure control mode, by increasing my pressure control, that's going to make these peaks bigger, which is going to add area underneath this curve. I can also do it by adding more, increasing my respiratory rate, which adds more area underneath the curve. Or I can do it by increasing my I time. So if I make my I time longer, I have a bigger area underneath that curve. So that's just kind of quickly to demonstrate or help you visualize how you can increase your mean airway pressure, the things that are affecting your mean airway pressure. Your book also has a chart on the top of page 1023 that talk about the factors that increase mean airway pressure, which are listed down here below. All right. So thinking about the effects of pressure on lung recruitment, okay? So I just want to make sure it's clear to you guys, we're actually recruiting lung tissue or opening up alveoli by increasing our PEP. Okay, so the more pressure I put into the lungs during inspiration, that's going to open up those alveoli. But my PEEP is used to maintain those open alveoli. So by increasing my PEEP, I'm going to increase the alveoli that stay open during exhalation, which is going to overall improve my patient's lung compliance. So your book talks about not only the PEEP that we have set, but we also talk about the PEEP that is created or generated by gas trapping in the lungs. Okay, so we set our PEEP, which is that extrinsic PEEP, right? That's the setting that we make on the ventilator. But we also, patients can have their own intrinsic PEEP by um, by gas trapping. So if a patient's not getting enough time to exhale, which is commonly seen when you're using like things like inverse ratio ventilation, which we're going to talk about in a little bit later, that expiratory, that gas that's going to get trapped in there is going to add to the total amount of PEEP that's in the lungs. Okay. So we do this. You guys have been monitoring this by doing those expiratory holds on our patients when you're doing your vent checks, and you see your set PEEP. And then you're going to get a total PEEP reading. You subtract from your total PEEP your set PEEP, and then you get the amount of auto PEEP that's happening in the lungs, or the amount of gas trapping that's happening in the lungs. So in order to increase our our lung volumes, we, can do that directly by increasing the tidal volume. So if I'm using volume control ventilation, I just am going to increase my tidal volume. If I'm using pressure control ventilation, remember that tidal volume is going to vary with changes to the lung compliance, and the airway resistance. Okay, so we demonstrated in lab the other week that if you don't have enough inspiratory time, your tidal volumes may not be that's going to affect our tidal volumes based on changes with like airway resistance. Okay. Oops, sorry. Your functional residual capacity, your book talks about functional residual capacity and PEEP. So the amount of functional residual capacity or volume that stays in our lungs during exhalation is going to be directly related to our PEEP level that we have set. So typically we're going to set higher PEEPs with patients that have decreased lung compliance. They're stiffer lungs, or if the presence of that restrictive disease. Any restrictive diseases are going to affect volume. They usually have either decreased compliance, lung compliance, or chest wall compliance that's causing the restriction, and we need to use increased levels of PEEP to overcome that. So that functional residual capacity in those PEEP is going to help improve oxygenation up until the point where overdistension is occurring. Once we hit too much PEEP, now my oxygenation is going to go down and my patient's going to start desaturating because of poor perfusion to the lung tissue, which we've explained a little bit earlier on. All right, so pressure volume curve and lung recruitment in acute respiratory distress syndrome. So I talked to you guys before about those pressure volume loops. Earlier on in the semester, and how that kind of shows different things about lung compliance. So if you're looking at your ventilator and you're looking at the pressure volume loop, the slope of that loop is your lung compliance. So your book uses this picture here to kind of help demonstrate some of this. So if you have a patient in ARDS, you can look at this loop, find that point here. This is your P flex point. Some ventilators find it for you. And this tells you, okay, so if you're thinking about this curve or the slope of this line, it's taking a lot of pressure up into this point to make a very little change in volume for this part of the curve. I'm going to use my highlighter. Okay. So for this part of the curve here, I'm using a lot of pressure and I'm not getting much change in volume. So that's a poor lung compliance up until this point. But once I hit that P flex point, I'm going to change to green, I'm getting a lot of change of volume with very little change in pressure. So my lung compliance got drastically better after this point here. So what this section is telling me is that if I set my PEEP to above this point here, my patients are always, my patient's pressure volume loop then is going to look like this. So the slope of this line is much better than the slope of this line, right? The pink line has a much higher slope than the blue line. So by setting my PEEP here, I'm going to improve my patient's lung compliance. So this upper, I'm just going to exit this drawing right now so you get rid of those. Okay, so this can be true of the upper inflection point as well to kind of tell you stuff about your patient's lungs. So you have your this upper point here. Oops, I'm going to use actually red because this is bad. Red means bad. So up here, you notice that the slope of this line changes again. So I go from having really good compliance in this little window here, between this pressure and this pressure. And then after I exceed this pressure, I don't get a lot of volume change for a lot of change in pressure. And this indicates over distension. We're going to call that the bird beak. That's what it's commonly referred to. Because after this point here, I'm adding all this pressure that's not generating a large amount of volume change. So it's kind of pointless to apply that pressure to the lungs. I'm just over distending those alveoli, right? So I want to keep my patient ventilating well. I want to keep their pressures within this window here, right? And we can use our pressure volume loop for that. Sometimes these points can be difficult to identify. Some ventilators will find them for you. Your book talks about lung recruitment maneuvers. This is when we would apply, like, typically we would put the patient's, a lot of times I've done this in CPAP. I'll switch them to CPAP and I'll apply 40 centimeters of water pressure CPAP to the patient's lungs for like a minute. And then I'll bring them back down and I'll drop them back down. And I've just popped everything open, and now I won't need as much pressure to keep them open. So recent, that's kind of the old fashioned way of doing it. Now we do like PEEP trials will do APRV as a way of doing this as well. Typically when we're setting our PEEP, we're going to be increasing our PEEP up to a certain point to optimize oxygenation without any detriments to blood pressure or hemodynamics. And we're going to be looking at which PEEP is creating the best oxygenation, best lung compliance for the patient. Oops, gotta get out of this drawing. Okay. Okay, so dead space ventilation. They talked before about that VQ mismatch. Increased dead space is always going to be an effective positive pressure ventilation as well. These are the kind of the pictures from their book that shows how during inspiratory, when we're using a mechanical ventilator, ventilation is going to be to the non-dependent alveoli. So in here, during mechanical ventilation, the ventilation is going to happen to the non-dependent alveoli, and perfusion is going to happen to the dependent alveoli. So your VQ mismatch gets worse. You're going to have an increase in that dead space ventilation, where ventilation's coming in, but you're not getting perfusion to it. Okay. Okay, so the whole kind of purpose of mechanical ventilation is to alleviate or lessen work of breathing. This is why we're putting patients on the mechanical ventilators, is to take away the work of breathing on the patient and put it on the machine. But there's several things with mechanical ventilation that can kind of get messed up where the patient ends up having an increased work of breathing due to things that we've set inappropriately. So things like the mode of ventilation, what your trigger sensitivity is, how much inspiratory flow we're giving the patient, all are going to affect their work of breathing. So I think it's important for you to break down work of breathing into thinking about the amount of work that the ventilator's doing and the amount of work that the patient's doing. So you can kind of even rewrite this. Stupid thing. You can kind of even rewrite this in your head if this helps somebody. That vent work plus my patient work is going to give me my total work of breathing. Okay. So depending on the mode you're picking, the vent could be doing all the work and the patient can be doing barely any of the work, or vice versa. Okay. How much work that the patient does in the vent has to do is also going to depend on the patient's lung compliance, chest wall compliance, airway resistance, their specific drive to breathe, right? And then different variables on the ventilator. So like sensitivity. If I set my sensitivity really, really light, my patient's not going to work that hard to trigger a breath. But if I have it set really high, my patient has to work harder. Peak flow rate is another one. A lot of asynchrony issues that we're going to be talking about when we get to vent asynchrony have to do with patients' flow rates not being met. Cycle coordination. So when the vent gets cycled off also is going to affect work of breathing. Like if I have my I time set inappropriately, my patient might want to cycle off way before. Their time constant might be a lot less than what I have set, which can cause cycle coordination issues. And then obviously the amount of tidal volume I've set for my patient. If I'm not meeting, that has a lot to do with flow as well. Which this is going to be a hard concept to kind of understand because, we talk about volume control, volume control, volume control. We always use volume control, but during assisted ventilation, actually pressure targeted modes are generally more capable of meeting those patient demands because I'm not setting the flow, right? In volume ventilation, the flow is set by the volume I have set in there and the inspiratory time I have set in there. So if I pick the wrong flow rate for my patient, they're going to have a lot of asynchronies or dysynchronies, and that's going to cause a lot of increased work of breathing for the patient. But in pressure ventilation, I'm setting that pressure control. I'm setting an inspiratory time, but my patient can control that flow rate and the tidal volume based on their effort a little bit. So, and their compliance and airway resistance. So actually, it's a lot easier to have a patient be a little bit more synchronous in pressure controlled modes of ventilation than volume controlled modes of ventilation. But again, the negative about pressure control is that I cannot control that minute ventilation. Right. So how do we go about minimizing adverse effects to positive pressure ventilation? So we want to make sure that we're decreasing the pressure. We don't want a lot of pressure on the patient's airways. We want to keep those pressures as low as possible. So typically we want our PIP to be less than 40, our PLAT to be less than, 28, 30. Usually we just usually round up on that one. We also want to make sure that we're managing our patient's secretions well. So we want to make sure that there's adequate humidification, that the patient's got good bronchial hygiene so that we're getting rid of excess secretions out of the airway so that's not causing obstruction and leading to higher pressure needs. We also want to be making sure that we're treating any bronchoconstriction with bronchodilators or anti-inflammatory drugs like steroids. In certain circumstances, we mentioned before that we want to keep our tidal volumes between 4 to 8 milliliters per kilogram. most of the time 6 to 8, but in certain circumstances, we're going to be on that low end, that 4 to 6 milliliters per kilogram to keep those pressures low. That's particularly true of patients with really poor lung compliance, like our ARDS patients. Anytime you have high mean airway pressures in the lungs, again, remember that's the average pressure throughout the entire respiratory cycle, that's going to have a negative impact on venous return. So more pressure in that thoracic cavity is going to make it more difficult for the blood to return to the heart, which then, if blood's not going in, if you don't have good preload, you're not going to have good cardiac output. Okay, so PEEP is used again to improve oxygenation. So that's particularly true when you have those shunt patients or refractory hypoxemia. Again, PEEP is used to maintain those open alveoli, increase that functional residual capacity, reduce shunting by opening up and ventilating, improving ventilation to close alveoli. Once those alveoli are open, they're easier and maintained open, they're easier to fill with volume, right? That half full balloon is easier to blow up all the way than a completely flat balloon. So it's going to improve our lung compliance. And then by improving our surface area for diffusion, we're going to be improving those PF ratios. We're going to talk a lot about when we're talking about making vent changes, about when to increase your PEEP and when to increase your FiO2. So big couple rules of thumb to pop in here for you guys. FiO2, you usually want to maintain your FiO2 at less than 60%. Okay. And that is, oops, I keep doing that. Less than 60% is usually the rule of thumb for FiO2. You want to kind of keep it less than 60%. So once our FiO2 needs is greater than 60%, you want to start increasing PEEP. So if you need more than 60% FiO2, instead of going up to like 70% here, you want to increase your PEEP. Okay. You want to, well, I'm going to teach you how to set optimal PEEP so that you avoid those like side effects like cardiac output, decreased cardiac output, things like that. We're going to do that in the lab like this week or next week, where we'll learn how to set optimal PEEP. So okay, so set optimal PEEP, which is the highest PEEP to achieve optimal oxygenation without cardiac complications, is kind of that definition. Okay. Okay. All right. So we talked about flow patterns previously. Okay. So we talked about flow square, decelerating, accelerating wave patterns. So your square wave pattern is typical of your like volume control ventilation usually. Your decelerating wave pattern is a lot of times typical of pressure control ventilation, but that's not always true, right? You've seen this on your ventilators. You saw on the servo the other week when we were doing our volume control exercises. You can see how you can have a decelerating flow pattern depending on the ventilator. So, but knowing the differences between these two. So square waveform, you're getting that constant flow rate, right? Your square waveform, your flow rate matches your peak, your constant flow rate. So your mean flow rate matches your peak flow rate. So that is, in case you guys need it drawn out for you again. Sorry, it takes a minute for this thing. I click on the thing for me to get an actual button. So this is your square flow pattern. Okay. Your decelerating flow pattern is, change color. Decelerating flow pattern is where you peak flow starts high and then the flow drops until you get into exhalation. Again, we're only looking at the top part of this flow waveform. Okay. So the benefits of decelerating flow waveform, usually you need less pip, decrease plateau pressures because your flow isn't staying constant. A lot of times your decelerating flow patterns can also decrease work of breathing, decrease dead space, tidal volume ventilation, decrease your PCO2s, increase PaO2s, increase MAP. So lots of benefits of that decelerating flow pattern versus um, versus square. Okay. Um, so during positive pressure ventilation, low flows can cause gas trapping and vent asynchrony. So typically your patients are going to want to use higher flow rates, shorter I times, so that you can allow for that full exhalation. All right. If you're not allowing fast enough flows, a lot of times patients are going to not only have that auto PEEP happen, but you're going to see flow asynchronies on that inspiratory end where you're watching the patient kind of sucking flow in mid breath because they're not getting enough of it, which can cause peak pressures. Finally, not many thoughts about this, but just trigger site and work of breathing is another kind of minimizing the adverse effects of ventilation. So trigger site, this is referring to sensitivity again, right? So this is your sensitivity setting. Okay, so this is just reminding you that this has to be set low enough so it's easy for the patient to breathe in when they want to get a breath from the ventilator, but you don't want it set too high that the vent's imagining patient effort that's not really there. So that's just kind of a reminder of what we kind of were looking at last week, or in the first couple weeks in lab, where the ventilator needs to only be reading the patient's efforts and not just maybe a leak or a loss of flow in the system. All right. Whew. I think I'm gonna keep going. I was worried that I was gonna need to do a part 3, but I think I'm gonna keep going here. So physiologic effects of ventilator modes. We talked about pressure control versus volume control. So the difference between these two when we're talking about pressure control versus volume controls is just what we're controlling um, in the patient's respiratory cycle. So am I controlling the volume or am I controlling the pressure? And if I control the volume, then the pressure is generated based on the patient's compliance and resistance. If I'm controlling the pressure, then the volume is variable based on the patient's compliance and area resistance. So remember, your book talks about continuous mandatory ventilation, or CMV. This means that all breaths are mandatory or mechanical and delivered by the ventilator at a preset volume or pressure, depending if we're pressure control or volume control. They get a breath rate and they get that set inspiratory time. So in CMV, we control the trigger, or we as in the ventilator controls the trigger and the cycle for each and every single breath. Okay. So when you're talking about volume control AC, um, Volume control, I'm setting that minute ventilation for my patients. That volume is guaranteed for every single breath. The pressure varies dependent on changes in the patient's lung compliance. Okay, it's very important because we use mostly volume control to make sure that we're setting a flow rate that matches the patient's needs. Okay, so I need to make sure that this flow matches what my patient needs. Otherwise, my patient is going to be trying to take in a breath while they're getting a breath because they're not getting enough. So again, the benefit of ACVC is that we have a very precise regulation of that gas exchange because I'm controlling the respiratory rate and I'm controlling the tidal volume. Okay. Oh, I think I said PRVC on this one, but I might have meant this is supposed to say, sorry. This is supposed to say PCAC. So PC AC. All right, so the benefits of PCAC, again, I'm controlling the pressure and the volume then is variable. So at that constant inspiratory pressure, that means there's kind of a lot of times this is good for patients with varying lung compliance in different areas of their lungs because that pressure is going to help open up or recruit those other areas of the lungs, whereas in volume control, the volume is going to go of like path of least resistance. So you might end up with all the volume in the more compliant areas of the lungs and not in the less compliant areas. So you're going to have that more even distribution of ventilation in pressure control ventilation versus volume control. And inspiratory flows, as I mentioned before, aren't as big of a factor because the patient kind of determines those. So even though we don't use it a lot, pressure control ventilation is a very good mode of ventilation for some of your really complicated respiratory patients. Because again, you're not going to have as much control over the flow, so there's going to be less flow asynchronies, and you're going to have there's going to be a little bit more even distribution of that ventilation. Okay. So additionally, your book talks about like pressure control, inverse IE ratio. This is a tactic we used to use a lot. We don't use it as much anymore now because we have APRB. But what this did was instead of having like a 1-to-2 or a 1-to-3 ID ratio, we would kind of have the inspiratory time match the expiratory time, or sometimes even exceed the expiratory time. So your inverse ratio ventilation just means that you've got like kind of a 1-to-1 ID ratio. So 50% of the time is used for inspiration, 50% of the time is used for expiration. Okay, so if you think about that and you think about what happens to your mean airway pressure, right? Mean airway pressure is all the time underneath this curve. So I'm spending more time in inspiration. I'm going to have a higher mean airway pressure, which this was used to help improve oxygenation on our really, 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 really stiff lung patients. So some studies have shown that there was an improvement with oxygenation using inverse ratio ventilation. But this obviously we're reducing the amount of expiratory time the patient has. So this tends to cause a lot of auto PEEP and then can tend to have a lot of perfusion issues or cardiac output issues. So not always isn't going to be effective for every patient, but we used to do this a lot or more often when you have patients with really poor lung compliance to try to open up their lungs and improve oxygenation. We're going to talk about APRV a little bit later on, and that being we'll kind of be able to show you why that took over. Um, so IMV is that partial mode support mode, or SIMV. This allows or requires a patient to do some of the work of breathing. Again, this should all be a refresher to you guys at this point. So, oopsies. Mandatory breaths or mechanical breaths are gonna be delivered at that set rate. So they're gonna be time triggered, time cycled, time triggered, time cycled, time triggered, time cycled. These breaths right here and here. Okay, but in between, the patient's gonna be spontaneously on their own at their own respiratory rate above the set and their own tidal volume. So here you see that this is a patient triggered breath. It's also patient cycled. Patient triggered, patient cycled, patient triggered, patient cycled. Okay. So typically, our IMV is going to be used for our patients that have pretty good lung function, that are recovering from like post-surgicals, or that they're going to be, coming out of their respiratory failure pretty quickly. So, and you're going to be kind of like weaning them off the ventilator fast. So that's usually when you're going to see your IMV modes used the most. All right. APRV. So this is that variation that I said on the pressure control inverse inverse ratio ventilation. So what we do in APRV, and this is going to make more sense when you see it on the vent in the classroom, but this is kind of like a combination. Some people refer to this as high-low CPAP. So I have a really high pressure, whoopsies. I have a really high pressure, Jesus, set up here at the top. This is my pressure down here. This is my pressure waveform. So I have a really, really high pressure set, and then I maintain that high pressure for like 4 to 6 seconds. So when you're setting APRV, if you haven't seen it yet, let me just type this out on the bottom. You're going to set a high pressure, so a P high. Okay. And then you're going to set a T high. Okay. So this P high is usually set at around patient's previous plateau pressure. Your T high is set anywhere from 4 to 6 seconds long. So this is kind of, and I really truly mean it when I'm saying that this is like high CPAP and low CPAP, because when the patient's here at their high pressure and that they're hot for that amount of time, the patient's able to spontaneously breathe. So patients taking little spontaneous efforts at that really high pressure. So you think about this as being a really good tool for recruiting alveoli. So studies have been done on this with its effects on ARDS patients, but patients that have really poor lung compliance do well on this because it helps recruit alveoli and keep them open. Okay, so then they spend like 4 to 6 seconds at this high pressure, kind of breathing spontaneously, and then you go down into these drops. You have usually a P low setting and a T low setting. Okay, and then you're going to adjust. These two are a little bit trickier to set. Usually I set my P low to 0. So Anya says 0. Some people use the same protocol that I'm referencing here, where you always set your P low to 0, because, and other places will say, oh, you need to set it at like 1 to 2 or something like that. But I'm in the set it at 0 camp, because your T low should be set to create auto PEEP. So I'm purposely not giving my patient enough time to exhale. Okay. And I will show you that in lab, how you set that specific to your patient. So what I usually do, this is what I'm looking at when I'm setting that right here. So I don't know if I can highlight that. Right here on my expiratory flow, you see how that expiratory flow doesn't come all the way up to the baseline. Okay, so this is my I'm going to draw on the baseline here. Okay. So usually this expiratory flow is ending about 50% away from the baseline. See how this peak flow, this is kind of in the middle, this point here is in the middle of the peak flow rate and the baseline. That's about 50% expiratory flow. And that's meaning that 50% of my volume didn't come back out. So that amount is getting trapped in the lungs and is creating that PEEP to keep my airways open for me. So if I add PEEP on top of that, way too much PEEP, right? So that's why I usually do I'm part of the set it at 0 camp. All right. So during those exhalations, a patient it's really, you're just dropping down to dropping the pressure back down to 0 so that the patient can exhale passively, not all the way though. And then you go right back up to that high CPAP pressure. Um, Typically, we see that patients have fewer hemodynamic side effects with doing this versus inverse or that inverse ratio ventilation, and a lot of it has to do with the fact that the patient's spontaneously breathing and creating negative pressure themselves. When your patients are on inverse ratio ventilation, they need to be sedated or paralyzed because there's nobody that naturally is going to want to breathe like that. So typically those patients end up getting sedated or paralyzed in order to be managed on this mode. But in APRV, we want our patients to be breathing spontaneously. This is actually, the patients that I've had on it seem pretty comfortable. They don't seem like they're agitated or anything, so less sedation's required for it. I really love APRV. I think it's a pretty cool mode of ventilation. I think sometimes that we don't use it enough because people are scared of it because they're not used to doing it. But the more you use it, the more comfortable you're going to become with it. CPAP, we've talked about CPAP before, so that's just that continuous breathing at one baseline pressure. So pretty much we're essentially just setting that PEEP, we're setting that baseline. Our alveoli are maintained open, but the patient has to produce their own respiratory rate, their own tidal volumes based on their effort. Pressure support ventilation. This is just kind of like CPAP, but when the patient triggers the breath, they're going to get a pressure to help support them during inspiration. So pressure support ventilation is usually patient triggered, patient cycled by flow. And then it's going to be limited by that pressure support that we have set. So we usually want to set at least a minimum level of pressure support to overcome the airway resistance in the ET tube. And then just overcome any other airway resistance the patient might be experiencing with secretions, bronchospasms, work of breathing. Again, patient in pressure support ventilation controls frequency, their inspiratory time, and their flow rate. That tidal volume is going to be determined by the pressure support level that we're giving them and their effort against their compliance and airway resistance. Typically, if your patient's alert and awake and ready to be extubated or close to being ready to extubate, they're going to really prefer this mode over other modes of ventilation because they can control things and they're going to be less asynchronous. Okay. All right. So proportional assist ventilation, this is where, as a respiratory therapist, you can set the ventilator to do up to 80% of the total work for the patient. So the ventilator is going to determine like the pressure, the flow, the volume, the I time based on patient's effort, elastance, resistance, and make up the difference. So patients in proportional assist ventilation, the patient affects everything, because the only thing you're really setting is what portion the ventilator of the work the ventilator does. So this this is usually a little bit more synchronous than pressure support ventilation. So if the patient's on proportional assist ventilation, they usually are getting better support from the ventilator, so they're going to be a little less asynchronous than when they're in pressure support ventilation. All right. So NAVA is kind of a little bit of the same concept. NAVA is essentially um, you using the patient's responding to the patient's effort, and kind of assisting them with that work of breathing. So instead of looking at changes in airway pressure and flow, NAVA looks at changes in that diaphragmatic activity. So for this, the patient actually has a cable down called an EDI cable, and it has to be placed at a certain point to measure that diaphragmatic activity. It actually reads out on the ventilator. We have NAVA capabilities on our vent in the classroom. So one week I'll swallow the EDI cable and I'll kind of show you this. And you can kind of see how that diaphragmatic activity is getting read by the monitor, and then the machine assists with that work of breathing on top of it. So really it's the parameter that you're setting is how much pressure the vent's going to deliver based on how much energy my diaphragm's producing with the contraction. So the biggest advantage of proportional assist ventilation or NAVA is that it's going to improve synchrony with the patients, because it's a little bit more susceptible to what the patient actually wants, and it kind of adjusts everything based on that patient effort. The other great advantage of this, at least with NAVA, is it does reward normal physiologic respiratory muscle involvement. So if you think about it, if I'm a patient on a ventilator and all I need to do is suck in a certain amount of flow, I can use my inspiratory muscles, my intercostal inspiratory muscles for that. Or I don't have to rely on my diaphragm to trigger that ventilator. I can use accessory muscles for it, which can be very detrimental for our COPD patients who use their accessory muscles for a lot of things and aren't using their diaphragm. But we really want our patients, like our COPD patients and our little micropreemie babies, to be using and strengthening diaphragm. So by using modes like NAVA, it forces them to use their diaphragm to trigger the ventilator, which improves their ability, I feel like, to successfully wean. All right. Our automatic tube compensation. This is kind of similar to the flow assist aspect of professional source. Oh God, PAV. But it's only looking at the airway resistance in the ET tube. So when you're using automatic tube compensation, you're putting in the tube diameter, tube length to help the ventilator calculate out that airway resistance in the ET tube. And then the goal of this is to eliminate that work of breathing in the tube. So this, you can adjust it to compensate for as much as 10% or 100% of the imposed work, which I don't know why you wouldn't always choose 100%. and it's applied during expiration, or it's usually applied during inspiration to overcome um, the 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 work of breathing to get through those ET tubes. uh, Adaptive modes and dual modes. This is your PRVC. Um, so PRVC is based on kind of pressure control ventilation. So um, what PRVC does is it, excuse me, um, so what PRVC does is, and it optimizes, or it tries to maintain a targeted tidal volume by adjusting pressure levels based on the patient's previous breath. So typically you're gonna, in PRVC, you're setting a targeted tidal volume, you're setting your respiratory rate, and you're setting your alarms, and you're going to your the patient is going to adjust things based on that targeted tidal volume. So it's giving you the advantages of with synchrony, like you had with your pressure control modes, where that flow can be a little bit variable to meet the patient's demands. Um, but it's still allowing you to target or control that patient's minute ventilation. Okay. Um, and the same can be true of volume support. So in volume support ventilation, this is just like pressure support ventilation, but instead of setting the pressure, when the patient triggers the breath, they're going to get a certain volume. But that volume is going to be delivered over a patient determined I time. So the patient's still controlling the trigger and the cycle in volume support, just like they controlled the trigger and cycle in pressure support. But in volume support, we're setting the volume. Pressure support, we're setting the pressure that the patient gets. Okay. Um, so adaptive support ventilation. This is usually a pressure targeted mode that optimizes the relationship between the tidal volume and the respiratory rate. So it uses like pressure ventilation again, that is gonna, adjust for flow to minimize your work of breathing and auto PEEP, um, and limit those peak airway pressures by adjusting the flow rate. So typically what we're going to input into the ventilator are going to be, your ideal body weight, your high pressure alarm, your PEEP, FiO2 rise, those types of things. And the ventilator makes adjustments based on, what an ideal vent pattern would be. Okay. So finally, we're going to talk about just patient position with optimizing oxygenation ventilation. So typically patients that are on ventilators are going to be turned frequently to avoid atelectasis, hypoxemia, secretion retention, and pressure sores. So typically they're every 2 hours are going to be turned. A lot of times hospitals use those kinetic beds um, to help rotate the patient. Patients that have unilateral lung diseases, so meaning like a pneumonia, so if I have left lower lobe pneumonia, um, typically that means that you're going to want to put my good lung down as much as possible to improve my ventilation and perfusion and oxygenation. So if I have a left lower lobe pneumonia, I'm going to be laying on my right side so that the lung that is getting ventilated is also getting perfused. um, in ARDS patients, These are the patients that most often improve in prone positioning. Some of you have already witnessed this. This is where you're putting the patient on their stomach and keeping them there. Usually, a lot of protocols are for 16 hours. So they're laying on their stomach for 16 hours. Um, and then getting flipped back to the supine position. So, number of studies have been done to show the benefits of prone positioning. Um, so, it can be difficult to do. You need a lot of people to flip the patient, ensure that all those lines of monitors don't get interfered with. Another big thing that you need to be concerned about with prone positioning is just skin breakdown. A lot of times wounds can happen due to different types of pressure points in that prone positioning. A lot of times patients get a lot of dependent edema in their face. So some places do not want you using like the Anchorfast securement devices for those types of patients due to skin breakdown issues. But like I said, a lot of benefits have been demonstrated to patients in using prone positioning, especially in ARDS. So usually if patients have a PF ratio of less than 100, they're going to be prone. All right, so that is going to end part 2. I'm going to do a part 3 for the last little bit.